Thank you. I appreciate the opportunity to be here presenting our work. I have no financial disclosures, and the other authors' disclosures are listed here. Contaminated, infected, and dirty wounds, CDC Class 3 and 4, increase morbidity during abdominal operations, including abdominal wall reconstruction. Operative techniques surrounding contaminated abdominal wall reconstruction are controversial, including topics such as whether to perform a single or multiple stage repair, wound management post-operatively, mesh versus no mesh repair, and when mesh is used, what type of mesh. Overall, there's no consensus on these topics, and though they are all important, the topic of our study is the type of mesh during a single stage repair. And so when it comes to mesh types, there are a variety of options available, which I will broadly categorize into 3 types. The first is non-absorbable synthetic, and this includes your polypropylene-based meshes. These have a long history of use, but are traditionally thought to be contraindicated in a contaminated setting due to increased risk for wound or infectious complications. Recent studies, however, have reported favorable outcomes, challenging this notion. Biologic meshes are created with an organic compound, such as human or porcine dermis. These materials can promote rapid vascularization and cellular ingrowth, potentially mitigating infectious complications. As a third category, absorbable synthetic meshes are created with bioabsorbable polymers, which hydrolyze slowly over time. These types of mesh, however, have limited long-term outcomes as it relates to complex abdominal wall reconstruction, and there's some concern that when they fully resorb, that the hernia will recur. Our group had previously reported data comparing biologic versus synthetic mesh in the CDC Class 1 and 2 wounds and found favorable and comparable outcomes between these groups. But we wanted to know how these meshes would compare in a contaminated setting in patients at higher risk for infectious complications. There have been numerous studies to also investigate mesh choice in a contaminated setting. While most of this data is retrospective, there have been a few prospective trials published last year. The problem with comparing these trials is that there's significant heterogeneity when it comes to patient selection, preoperative care, intraoperative techniques, postoperative wound management, and reporting of the data. Even the definition of contamination varies, with some studies using CDC wound class and others using ventral hernia working group grading system. And so the purpose of our study is to compare biologic versus synthetic mesh in patients with CDC Class 3 or 4 wounds undergoing abdominal wall reconstruction. Our primary outcome was hernia recurrence, as documented on physical exam or CT scan, and secondary outcomes included mesh and wound complications, as well as readmission and cost. Data was collected from a prospectively maintained institutional hernia database, and patients who met the following criteria were included. They must have undergone open abdominal wall reconstruction between 2006 and 2019 with either a CDC Class 3 or 4 wound. They must have had either biologic or non-absorbable synthetic mesh placed. We compared biologic mesh against synthetic mesh and performed multivariable analyses of risk for hernia recurrence and mesh infection. All surgeries were performed by 5 expert hernia surgeons at a high-volume hernia care center. Surgeons were similar with regards to their practice of patients preoperatively, and all performed comprehensive preoperative exams, often relying on multidisciplinary teams to coordinate complex care. And all surgeons adhered to principles of preoperative optimization of modifiable risk factors. Here we start with some of the results, and this will show you the baseline characteristics. There were 335 patients in the biologic group compared against 51 in the synthetic mesh group. These groups were well matched with regards to age, sex, BMI, smoking, and comorbidities, but patients in the biologic mesh group had larger hernia defect sizes on average and a higher rate of a prior failed ventral hernia repair. Biologic mesh patients also had higher rates of infected mesh or enterocutaneous fistulas present, which is reflected in a higher proportion of CDC Class 4 wounds. On the other hand, synthetic mesh patients, most of their contamination was related to the presence of an ostomy, and therefore a majority of these patients had CDC Class 3 wounds. Here we see a breakdown of the different mesh types within each group. For biologic mesh patients, almost 3 out of 4 meshes placed were stratus mesh, which is a porcine-derived mesh. In the synthetic group, All were polypropylene-based meshes, and most of these were medium or low weight. Taking a look at some of the operative details, we can see that there was no difference in rates of preoperative Botox injection, and that operative time was above 3.5 hours for both of these groups. The biologic mesh group did have a higher rate of total component separations, and there was no there's no difference in rates of concurrent pendiculectomy between these groups. Fascial defect closure was achieved for a majority of patients, and while synthetic mesh sizes were larger on average, there was no difference in the location of these meshes. Most of these were placed in the preperitoneal plane, and when fascial defect closure could not be achieved, patients received a bridging mesh. Delayed primary skin closure was performed much more commonly in the biologic group, as we tend to use this technique for patients with CDC class 4 wounds. Operative charges in this study were higher in the biologic mesh group. Here we see the post-operative outcomes. There was actually no difference in recurrence between these two groups, with 10.4% of biologic patients identified as having a recurrence and 17.6% of synthetic mesh patients. This is at 25 and 42 months of follow-up, respectively. The average time to recurrence was about 16 months for biologic patients and almost 9 months for synthetic patients. And with regards to wound complications, there was no difference in the overall rate of wound complication, with about a third of patients in both groups experiencing any wound complication. Analyzed individually, there was no difference in rates of wound infection, seroma, hematoma, or intra-abdominal abscess. We found that the median length of stay was a day longer in the biologic mesh group, but there was no difference in 30-day readmission rates. Total hospital costs here was higher in the biologic group as well. On multivariable analysis, we found that wound complications and bridging mesh both significantly increased the odds of hernia recurrence. In this model, factors that were not significant included CDC wound class, mesh type, mesh or defect size, and BMI. Taking a look at mesh-related complications, we found that in the synthetic group, there was an almost 10-fold higher increase in the rate of mesh infections. And furthermore, of synthetic mesh patients who developed an infection, 2/3 of those mesh infections required return to the operating room for complete mesh excision. The remainder of patients with infected mesh were managed non-operatively with intermittent antibiotics. On multivariable analysis of mesh infection, we found that synthetic mesh and wound complications significantly increased the odds for mesh infection, while CDC wound class, mesh size, hernia size, and BMI were not significant. To recap, we found that biologic mesh patients, while having similar comorbidities as synthetic mesh patients, biologic mesh patients had more prior failed ventral hernia repairs with larger defects and higher rates of component separation. There were higher proportions of CDC4 wounds as well. And despite this, outcomes compared to synthetic mesh were similar with regards to hernia recurrence and overall wound complications. We did appreciate a higher cost in the biologic mesh group. However, the biologic mesh group had significantly lower rate of mesh infections. In this study, we found that wound complications and bridging mesh significantly increased the odds for hernia recurrence by 6 times and 13 times respectively, and that odds for mesh infection were increased by synthetic mesh use and wound infections. Furthermore, for patients who did develop mesh infections, 2/3 of synthetic mesh infections required return to the operating room, while none of the biologic mesh patients did. And so from this data, we have 3 main takeaways. The first is that perioperative wound management is important, as wound complications are linked to both recurrence and mesh infections. The second is that you should avoid bridging mesh, and this is no surprise, as this is linked to higher rates of hernia recurrence. And finally, from this data, we find that biologic mesh is preferred over synthetic mesh in patients with CDC class 3 and 4 wounds undergoing abdominal wall reconstruction, given similar rates of recurrence and overall wound complications, but fewer and less severe mesh infections. Thank you. I look forward to answering questions.
Thank you.
Thank you.